Hey everyone, and a massive welcome to all our first-year MBBS viewers out there. Whether you're prepping for your university profs, bracing for an upcoming Physiology Viva, or just gearing up for your very first clinical postings, you are in exactly the right place for this explainer. Today, we're looking at the heart not just a standard anatomical organ, but as a relentless, perfectly rhythmic two-stroke pump. We're going to break down the mechanics, the pressure changes, the sounds, and ultimately why every bit of this basic science actually matters for your future patients. Okay, let's dive right into this. Have you ever actually stopped to think about the sheer speed and precision of a single heartbeat? It is honestly mind-blowing. Every single time your heart beats, an incredibly complex symphony of electrical signals, mechanical movements, and pressure changes happens in an absolute flash. Under normal resting conditions, this entire sequence completes in roughly 0.8 seconds. To make sure we hit all those high-yield concepts you need, here's our roadmap for today. We're going to cover the basics, ventricular phases, decoding that infamous Wiggers diagram, the physiology of heart sounds, and finally, applied physiology. All right, Section 1, the basics. Let's establish the fundamental timeline of a resting heart. So that magic number we just mentioned, it's 0.8. If you have a patient with a normal heart rate of, say, 75 beats per minute, the total duration of one entire cardiac cycle is about 0.8 seconds. It's literally just the simple math of 60 seconds divided by 75 beats. In that tiny fraction of a second, the whole system fills up and forcefully pumps out. Now, by definition, the cardiac cycle is just the cyclical repetition of systole and diastole from beat to beat. Systole simply means contraction and emptying, it's the big squeeze. Diastole means relaxation and filling, the recharge phase. And here's a quick pro tip for the wards. While the atria and ventricles definitely have their own separate cycles, unless your attending specifies otherwise, the words systole and diastole always refer to the main engines down below, the powerful ventricles. Let's break down that 0.8 second baseline. Atrial systole is a super quick 0.1 seconds. Then ventricular systole takes about 0.3 seconds. And ventricular diastole, that crucial relaxation phase, takes up the remaining 0.5 seconds. You'll notice right away that diastole is significantly longer than systole at rest. The heart actually spends most of its time just relaxing, filling up with blood, getting perfectly primed for the next big squeeze. Moving on to Section 2, ventricular phases. Let's zoom in on exactly how that systole and diastole play out. Ventricular systole basically happens in 3 distinct steps. It kicks off with isovolumetric contraction. Now, I want you to think of this like trying to push open a really heavy locked door. The ventricles are contracting hard, but both the AV and semilunar valves are locked shut. The blood has literally nowhere to go, so the volume stays exactly the same, hence isovolumetric. But the pressure inside, it spikes massively. Once that pressure finally bursts past the aortic pressure, boom, the doors fly open. That gives us rapid ejection, forcefully pushing out about 80% of the blood. And that's followed naturally by reduced ejection as the contraction starts to run out of steam and the pressure begins to fall. Next up is ventricular diastole, which we map across 5 phases. After a brief little pressure drop in protodiastole that closes the semilunar valves, we hit isovolumetric relaxation. All valves are closed again and the pressure just plummets. When that ventricular pressure falls below the atrial pressure, the AV valves pop open. This triggers first rapid filling. It's honestly a lot like the doors of a Mumbai local train opening at a busy station. All that blood that was just waiting in the atria suddenly gushes in. That alone accounts for 70% of ventricular filling. This initial rush then slows down into a phase called diastasis and finishes up with the atrial kick, an active final squeeze from the atria to pack in that last bit of blood before the whole cycle starts over again. All right, Section 3, decoding the Wiggers diagram. Time to tie all these moving parts together. Now, I know the Wiggers diagram looks notoriously intimidating, but don't let it overwhelm you. The ultimate cheat code here is to simply read it vertically. If you pick a single moment in time on the horizontal axis and just look straight up, it all makes perfect sense. You can see exactly how the electrical trigger from the ECG, say the QRS complex, kicks off the mechanical contraction. Follow that vertical line up, you'll see ventricular pressure shoot up, which forces the aortic valve open, and simultaneously, the volume curve absolutely plunges as blood gets ejected. It is just a brilliant visual cause and effect cascade. And here is the exact same data, just from a totally different perspective. The left ventricular pressure volume loop. Instead of mapping everything against time, we're graphing volume directly against pressure. This loop perfectly traces a single beat. You got filling at the bottom, the straight vertical line going up during isovolumetric contraction, the top curve where ejection happens, and the vertical drop of relaxation. What's really cool is that the area inside this loop, that actually represents the total pumping work done by the left ventricle in a single cycle. It visually ties together all those phases we just went through. Section 4, Physiology of Heart Sounds. Let's transition from what the heart is doing internally to what you actually hear at the bedside. When you've got your stethoscope on a patient, you'll be listening for that classic lub-dub rhythm. The first heart sound, S1, or the lub, marks the very beginning of ventricular systole. It's a low-pitched, relatively long sound that happens when the atrioventricular valves, so the mitral and tricuspid, close. Then you have the second heart sound, S2, the dub. This marks the beginning of ventricular diastole. It's a much higher-pitched, shorter, almost snapping sound, and that's associated with the closure of the semilunar valves, the aortic and pulmonary.
Now, I want to clear up a huge misconception, and this is a guaranteed Viva question. The actual slamming together of the valve leaflets is not what makes the sound. Think of it more like a ship's sails suddenly catching the wind. The sound actually comes from the sudden tension and vibrations of the leaflets, the heart walls, and the blood column itself. Also, the left side of the heart is kind of an overachiever. It usually finishes its job just a fraction of a second before the right side. Because of this, the aortic valve closes just before the pulmonary valve, giving us a perfectly normal, physiological splitting of the S2 sound when a person breathes in. But if you ever hear a splitting of the S1 sound, watch out. You might be dealing with pathology, like a bundle branch block, where one ventricle is contracting noticeably late.
Finally, Section 5, Applied Physiology. Let's bring all this basic science directly onto the clinical wards. Whenever blood flow inside the heart becomes turbulent, it creates a whooshing sound that we call a murmur. Clinically, two major mechanical failures cause this. The first is stenosis. Imagine putting your thumb over the end of a running garden hose. The valve is stiff and narrowed, forcing blood to accelerate through a tiny opening, which creates a ton of turbulence. The second failure is regurgitation or insufficiency. In this case, the valve is like a broken, leaky door hinge. It just doesn't close all the way, so blood flows backward into the previous chamber, which again creates that turbulent murmur sound. And whether it's a systolic or diastolic murmur, well, that depends entirely on which specific valve is damaged and what phase of the cardiac cycle the heart is currently in. Let's rapid fire a few high-yield clinical correlations that are absolute favorites for next and NEAT PG exams. First step. In systemic hypertension, the arterial pressure out in the body is abnormally high. This actually forces the semilunar valves to snap shut with much greater force, making that S2 sound noticeably louder. Second, if you spot an inverted T wave on an ECG, that is a massive red flag for myocardial ischemia. The damaged heart tissue literally alters the electrical repolarization current. And third, when a patient's heart rate increases rapidly, the overall 0.8-second cycle shortens, obviously. But here's the kicker. That slow-filling diastasis phase we talked about earlier is reduced much, much more heavily than systole. And I want to leave you with a provocative final thought on that exact point. When a patient goes into severe tachycardia and their heart rate shoots way up, we know diastole takes the biggest hit in terms of timing. Well, since diastole is the crucial time when the heart fills with blood, what do you think happens to ventricular filling if there's literally no time to relax? And consequently, what kind of dangerous clinical impact does that have on the overall cardiac output being pumped to the brain and the rest of the body? Think about how these basic millisecond mechanical timings truly dictate life or death in a critical care setting. Thank you so much for joining this explainer. Keep studying those charts, stay curious, and I'll catch you in the next one.